Well, hi everyone. I am super excited. I have Dr. Mark Gordon with me, who is the world's leading expert, I think, on traumatic brain injuries and hormones. Dr. Mark, thank you so much for coming on the show. I've been excited all week about interviewing you, and I hope I do a good job because there's just so much nuance to your information that you share, and it's very complex stuff. So we're going to give it a whirl today and see how we go. Welcome to the show, Dr. Mark.
Thank you very much.
Can you give us a little bit of your background? Like, how did you end up in the space? We're working with veterans and hormones and brain injuries and all of this sort of space.
How much time did you put aside? Well, first off, I'm not an expert. I'm just well-read, okay? Leave that terminology for someone else who needs it. I just enjoy reading and have developed an understanding of, as you said, a very complex world that started with my own 6 head traumas that led me into needing an antidepressant, or perception of needing an antidepressant back in the 90s. So I read, and even though I was depressed and not doing very well emotionally, socially, family with 3 daughters and a loving wife and so forth, and a growing business, put on a medication, and it really wasn't doing anything. And in my reading, I came across an article that set the stage for me that when you have traumatic brain injury, a head injury, that you can have the hormones in the brain shutting off. And so I got my blood work done. So I got growth hormone, testosterone, thyroid, DHEA, pregnenolone, all these hormones done. And it was found that I had 3 hormone deficiencies: growth hormone, testosterone, and thyroid. And I didn't know that that was the problem at that moment. But when I replenished it, it was a world-changing kind of situation. I got my personality back. I became more extrovert. I was not in need of a medication that didn't work. And then I went back to my patient population that I'd been taking care of with hormone therapy and started being more inquisitive about psychiatric-related stuff. Everybody had a history of head trauma, and I was taking care of their hormone deficiency associated with depression, anxiety, bipolar. So in my deep dive in the literature, it became very clear that head trauma alters the chemistry of the brain, which allows the brain to start going awry. And that is the psychiatric. And that's how I got started. And I was doing anti-aging medicine in the beginning. And, I was in Australia, New Zealand, talking about hormone replacement. But the question really became, what is the actual mechanism leading to the loss of hormones? Is it trauma? Yeah, it's trauma. But what is about trauma that creates the problem? And that's inflammation. So anything that generates inflammation in the brain will shut off the brain's ability to regulate the brain's hormones and the hormones that are produced below the neck. Which brings us to a topic which is called neurosteroids and neuroactive steroids. Neurosteroids are the hormones produced in the brain by our own brain cells from cholesterol. So if you mess with cholesterol, how do you have the substrate to make the hormones in the brain, let alone the hormones below the neck? Wow. That is the problem. So anything that creates inflammation will lead to the shutting off of the area of the brain called the hypothalamus that controls the pituitary gland's production of something called luteinizing hormone that turns on testosterone estrogen production in women through the thecal cells, and in males, the Leydig cells for production of testosterone. We also get estrogen, so it shuts it off. So the goal for everything we do is to recognize that the hormones have been impaired and the causation is inflammation. So we have 2 avenues to address: reduction of inflammation and regeneration of the hormones made in the brain.
Wow. Yeah. Well, that's such a succinct explanation, actually. So, and inflammation in the brain is epidemic, right? Or especially right now, post-COVID, there's all that as well. So it's not just traumatic injuries where you've actually torn the, axons and neurons and it's also chemical-induced brain injuries or viral-induced brain injuries and medication-induced,
Absolutely.
There's all of these ways.
Right. Well, in what we're dealing a lot with now is post-vaccine conditions. They call it
Yeah.
long COVID, they call it infertility, they call it depression, they call it anxiety. All these came out of the secondary effect of an immunization, whether or not it's a flu vaccine or anthrax or COVID or this, that, or the other. They all run the risk of causing greater inflammation by turning on the immune system. When you
Hmm.
turn on the immune system, it starts producing a group of chemicals called cytokines. And these cytokines are inflammatory chemicals. Those inflammatory chemicals can be generated for, as you said, other medication, vaccines, surgery, fracturing a bone, having dysbiosis, which is the microbiome, the bacteria of the gut.
Hmm.
After you take an antibiotic, it alters it. After certain vaccines like the COVID, it destroys a lot of the bacteria in the gut that stimulate a healthy immune system from the gut up. So we've altered the biochemistry throughout the body, and there's a lot of synergy that happens. The gut helps to protect the brain, but it can also create a problem in the brain. We see it quite often in people with autoimmune diseases where their stomach or their joints or their ligaments produce inflammatory cytokines that go into the brain and create depression. How do we know
Absolutely.
that as a fact? It's because when we treat things like psoriatic arthritis, rheumatoid arthritis, celiac disease, and ulcerative colitis with the appropriate medication, which drops the inflammation, the chemical interleukin-6, tumor necrosis factor alpha, the depression disappears along with the improvement in their symptoms.
Hmm.
So
Hmm.
it's a cause and effect, which, theoretically, or in the past, they said, oh, the reason why, you've developed this complaining attitude and everything's a bother is because you're depressed. They don't correlate the depression being
With
derived
the
from illness.
Yeah, yeah, yeah. There's an actual reason for it.
There's a
A- a-
solid reason.
Yeah, there's a solid reason, and this is like quite a relief when you talk to people like this. And like in my clinic, I do, and you get them to, and there's we can't unfortunately do what are those spec scans over here where we can actually see some of the damage in the brain, which would be great, but we can't because we don't have it. There's a lot of things we don't have down here, by the way, but at the basis of it is the immune system going awry. So this is, I have a biotech company, and one of our flagship products that we're just bringing to market at the moment is going after immunosenescence, right? We want to support the immune system. We want to downregulate the IL-6 and the NF-kappa B and the tumor necrosis factor alpha and the IL-1 beta and all of these cytokines that are often upregulated, and especially as we get older, because age is also going to be playing into this whole picture. So if we're going to have optimal health, we need to support our immune systems for a start, and we need to get the inflammation down in the brain. And then the part two of this is that the hormones start to go awry when you have the inflammation. So your approach is to first attack the inflammation, second look at the hormone situation of the person. Would that be correct?
We do it concurrently. We do it concurrently, and the reason
Mm-hmm.
is that the not misinformation, but the incomplete information that people have is that we look at our hormones, testosterone, estrogen, progesterone, pregnenolone, allopregnenolone. We look at them as gender hormones or
Yeah.
reproductive hormones. Well, it turns out that every single one of our hormones has what's called a pleiotropic effect. Pleo means many. So they have many layers of benefits. Well, it turns out that testosterone, aside from all the great things we hear about testosterone, has a direct effect on our immune system. That effect is that it elevates the immune cells, the CD4, the CD8 cells, part of the T cell lines, to increase their production of interleukin 10.
Yeah,
Interleukin
which is
10
anti-inflammatory. Yep.
is the major anti-inflammatory. And what does it do? It shuts down interleukin 1 beta, 6, and tumor necrosis factor alpha. So when we're aging and we lose the hormones in our brain, estradiol, the MAPK, the kinase that turns on kinase for phosphorylation that creates tau protein that leads to, things that are akin to CTE, chronic traumatic encephalopathy. I'm paper right now looking at multiple sclerosis, Alzheimer's, traumatic brain injury, and PTSD from the standpoint of what precipitates the process. And it's all trauma. The video that I just released on multiple sclerosis, which we've now reversed 6 patients with it. We just got 2 more coming in. One is a lieutenant in the Navy, Tim. The article is, the video is up on the YouTube channel.
Yep.
Well,
I've
it
seen
turns
that.
out that in my deep dive of reading, they found that 30% of the multiple sclerosis cases have a history of traumatic brain injury. And in
Wow.
Tim's case, he had 2 major loss of consciousness at less than 10 and then 16 or 19 it was. And that predisposed him to developing the level of inflammation by the time he was 36, where he woke up, he couldn't see in his left eye, had weakness in his hands and foot. And then he's now 11, almost 12 months in remission on no medication, just
Wow.
by correcting the inflammation. We've got a 94-year-old with dementia, that's gone. We've got 3 people with Parkinson's disease, which is an inflammatory causation. And we now know the mechanisms. When you have head trauma or you have free radicals that are generated from a medication or ulcer or gastritis or Crohn's disease or celiac disease or whatever, what happens is, or vitamin A, or retin A, Accutane, or the methylquin group, the what do they call it? The ciprofloxacin, the floxin groups,
Yep.
that they shut off the ability of the brain to convert cholesterol to pregnenolone, to progesterone, to allopregnanolone. So that's how you get all these problems. So it's in the literature, it's in the biochemical neuroendocrinology, which is the field that I've been working in since 2004 for 20 years now. And what we found is that the interruption of the conversion of cholesterol to pregnenolone, you lose 35 hormones.
Exactly.
And you can lose those 35 hormones by taking testosterone, by taking estradiol. And that's why you need to supplement with pregnenolone, which is one major pathway in the brain, and with DHEA, which is another pathway in the brain. And as we were talking before recording, at the website, I have a video, I think it's like 10 minutes, which is the argument for pregnenolone and DHEA when you're taking testosterone. And it's very simplistic. You take testosterone or estrogen, and it shuts off the brain's perception that you need luteinizing hormone. Luteinizing hormone is the gatekeeper for all the hormones in the brain, all the steroidal hormones in the brain and body, and you lose it. So you've got 2 left, testosterone and estradiol, but there's a whole bunch of other ones that protect the brain. Allopregnanolone, which is a byproduct, a metabolite of progesterone, is now a pharmaceutical drug in the United States and probably in Australia and New Zealand and wherever, which is called Zulrosso or brexanolone. And what is it for? Antidepressant, anti-anxiety. And it's because you can't make the allopregnanolone. What's stopping you from making allopregnanolone? A lot of medication that's being given out there.
SSRIs and things like that.
Statins and antibiotics and cardiac medication, just a whole bunch of meds. And this is what I look at in the pharmaceutical world and neuropharmaceuticals and neuropsychopharmacies, the influence of these medications on the ability of our brain to do what they need to do. Let me shut that off. Okay. So
and this is like this is actually crucial information. Like I had a change in brand because I'm on a hormone replacement therapy, and I'm learning more and more as I discover more of your work and try to understand it, because there's a lot to learn, and we've got some brilliant experts, thank goodness, in New Zealand that are helping me. Shout out to Dr. Harris and Dr. Jones. but we had a change in testosterone, the type that was funded here, and it was much more powerful. And I ended up overshooting the mark on the testosterone, right? So I just got some blood tests back a few weeks ago, and because I was getting more muscle than I normally had, and I'm like, hang on a minute, I might be overshooting the mark. So I went and got a test, and yeah, sure enough, 5x what it should be, right?
Yeah.
And that has shut down the DHEA, the pregnenolone, the allopregnenolone, the other things. So I was noticing, I was getting very angry, grumpy. So all of these are signs. And so now we're going to rectify the situation, hopefully, and get it right and balanced. And this is the importance of when you're doing hormone replacement, that you are under somebody who knows what they're doing and the nuance of this conversation. And you got to watch, when you change a brand or something like that, you're getting what you think you're getting and not overshooting the mark. But this is the problem. Like, you see a lot of young men, and we've got an epidemic of low testosterone in our male population, and a decrease in fertility. And there are many reasons, xenoestrogens and things in the environment and medications and so on and so forth. Our food. And you get all these male clinics popping up that are just putting, all right, you just got to put testosterone back in. It's all about testosterone. It's the only hormone that is actually ever discussed, right? And it's like, you're missing the picture here. Like, in the DHEA, the pregnenolone, understanding your cholesterol, and then addressing the inflammation in the brain that is causing the low T, is not being addressed. It's just smash a whole lot of testosterone, and then you feel great. They feel great for 3 or 4 months, and then they come back and they say, "Oh, I don't feel great anymore. I was like really good the first few weeks. What's happening now?" And the doctor goes, "Oh, just take a bit more. Have a bit more testosterone." And then we end up shutting it down even further. And then we burn these guys' systems out, and they lose their fertility, and then we can't restart their system. This is what's happening over and over again now.
Yep.
If they're lucky enough to even get testosterone, a lot of them are just left hanging, and then they feel weak and depressed and, not full of vim and vigor and action like they should be.
They lose their masculinity. Yeah,
Mm.
I don't use testosterone very much anymore. What I do is I help to regenerate their own production, and that's through the use of things like clomiphene or eclomid, which I don't know how available it is to you.
Yeah,
but
we do have it.
You do have it, and that's what I use first line, because, as you just said, when you give testosterone, what you said is, iconic of what I used to see in my practice, where guys were coming from the male clinics to us because they would get onto a testosterone right off the bat, and 4 to 6 months later, they'd start feeling worse, and they'd go back to the doc, as you just said, and said, "Doc, I felt great during the first period of time, but now I don't." "Oh, just increase your testosterone." Well, that just makes it, as you said, worse. And the mechanism is the fact that they're losing 35 hormones in the brain. And that's why they're feeling bad, okay, is because of that. And on the flip side, in people who have a sensitivity of free testosterone in the brain, if the testosterone level gets too high in a unique individual, it will turn on a chemical called adenyl cyclase, which will cause them to become agitated, aggressive, emotionally volatile, okay, anxiety, panic attacks. And that's because of turning on this adenyl cyclase. And that causes, it's like speed in the brain. And it's like
that's a genetic thing, isn't it? Some people have that. Yeah.
Right.
Is there a way to test that? Is there a test for that?
No,
you can't tell.
That's why if you use testosterone, you monitor it to make sure that they don't go outside the physiological limits.
Yeah.
And I see a lot of guys who come in who are so much higher than they need to be. And I tell them that, the reason why you see a elevation in dihydrotestosterone, DHT, which is the active metabolite of testosterone, and why you see estradiol, or estradiol, as you guys might call it, is because the body's trying to tell us too much testosterone. We got to reroute it to the other things to drop the level before you kill yourself. The liver gets affected, the brain gets affected, the sebaceous glands get affected. You get shrinkage of the testicles, shrinkage of the ovaries. So it's not a risk-free proposition.
No. Yeah.
And as you said, you need to have someone who really understands the full depth. But here in the United States, and I know in other countries, that they're giving testosterone out as a panacea,
Yeah,
you know,
without the rest of the picture.
without the rest of the picture. Oh, you're low in testosterone. Let's give you testosterone instead of let's see what other hormones are affected. Now, we know that the spike protein from COVID, whether or not you had the active disease or infection, not disease, infection, or you received it through artificial means, that the spike protein creates this damaging inflammation in the brain, which, according to many articles, are using it to account for why infertility, low estrogen, low testosterone is occurring.
Yep.
It's not genetic. It's the fact that the inflammation is shutting things off. And it was in 2013 that a major article came out talking about the mechanism. It was a brilliant article, the mechanism by which the inflammation shuts off the astrocytes, which are the brain glia cell, is one of the glial cells. And you need the astrocytes in a healthy condition to help the area of the brain called the hypothalamus to generate a chemical, a hormone called gonadotropic releasing hormone.
Mm-hmm.
So if the astrocytes are not functioning, the hypothalamus cannot effectively release gonadotropic releasing hormone that goes to the pituitary to turn on FSH, follicle stimulating, to keep the ovaries and the sperm production, and cannot turn on luteinizing hormone. In the side effects also is it downgrades the production of thyroid, downgrades the production of growth hormone.
Wow. Yeah. Yeah. That's
Okay?
another whole party to talk about, isn't it?
Yeah. So I don't look at things one channel. It's all together. It's this synergy that occurs in the brain and how the hormones, like there's a compound, immune chemical called fractalkine.
Mm-hmm.
Fractalkine is regulated by cortisol, negatively regulated. Why? What's the function of fractalkine? Fractalkine is what keeps the inflammation in the brain low. And it's by regulating the cells, the immune cells in the brain called microglia. Microglia have 3 different phases of their life. M0, which is sedentary. They're just looking for virus, bacteria, and mold and debris from trauma so they can clean it up. And once they're activated, they go into what's called the M1, which is the pro-inflammatory state. And then after inflammation is taken care of in the acute phase, the M2 phase is anti-inflammation, where you get the interleukin 12, the interleukin 10, the 2, the 4, and so forth, to help with cleaning up the mess and dropping inflammation. What happens in ballers or headers or the guys who play soccer or any kind of head trauma is that you keep this process going.
Activated.
Activated. So instead of it being an acute process, a classical acute process of the brain's immune system being turned on is when you get a cold. You get a cold, you feel fatigued, irritable, you don't want to eat, you're in bed, you're emotionally volatile. And then in a couple of days to a week, you feel better. Why? Because interleukin 6 went sky high and now it's come back down. Wow. So it's the regulation of the cytokines that create this problem. So the fractalkine generated by neurons keep the microglia in a sedentary M0 state. But cortisol comes around under stress. You could be watching some bad politics. You can be watching a bad ball game. You can be under family stress. You can be in a bad relationship. You can be at a bad job, and your cortisol level goes up, fractalkine level comes down, and you start activating your microglia, your glial cells, and they start dumping the inflammation. Part of the problem that occurs with dumping the inflammation are free radicals. Free radicals, reactive oxygen species. That's why things like HBOT has a role to play.
Hyperbaric is huge.
Hyperbaric and Dr. Scott Shear and so forth.
Yeah.
So the benefit of the detriment of the free radicals is that one of the free radicals called peroxynitrite. Peroxynitrite is made from a reactive oxygen, which is not good. It's
Mm-hmm.
generated from mitochondria under stress, biological activity, making energy to try and fix things, to generate healthy things instead of dealing with all this negative chemistry. The mitochondria produce ATP in a process called oxidative phosphorylation,
Mm-hmm.
and the body has to handle this negative charged oxygen molecule. So what does it do? It pairs it up with something called nitric oxide.
Mm-hmm.
Nitric oxide has two very important roles in the brain. One, it helps to dilate the blood vessels so
Which is
blood can
good.
flow,
Yep.
which is good. The other thing is it's an intracellular signaling mechanism, nitric oxide signaling. So what happens is when you have too much reactive oxygen, it steals the nitric oxide and forms a chemical called peroxynitrite. Peroxynitrite damages enzyme systems. Some of the important enzyme systems that it damages is the conversion of some amino acid called L-tryptophan, which an enzyme called the hydroxylase converts it to melatonin.
Mm-hmm. Yep.
Converts it to
Serotonin.
serotonin.
Yep.
So if
Serotonin.
you don't make serotonin, you'll end up having depression, possibly.
Exactly. Yeah.
And then serotonin converts to
Goes to
melatonin. And
melatonin.
if you don't have melatonin, you can't sleep.
Mm-hmm.
So if you can't move tryptophan to serotonin to melatonin, tryptophan starts accumulating in the blood, in the brain, and it gets converted to a chemical called kynureninic acid.
Kynurenate pathway. Yeah. And that's
Kynureninic
inflammatory.
pathway, and
And
it
quinolinic.
creates inflammation. Dr. Takamura out of Japan spent his life doing research, psychiatric research, mental health research relative to kynureninic acid. And what did he find? That it's the cause of MDD, which is the depression disorder.
Major depressive disorder.
Major depression disorder, MDD. And he believes that it's the kynureninic acid that's the problem, not serotonin. And if you look at the 2017 group of articles that started coming out of the UK, what did they show? They found people with high levels of serotonin who had depression. They found people with low levels of serotonin who didn't have depression.
I heard that on your lecture. Yeah. So the SSRIs are not going to do anything by in that case.
Correct. And that's why you have failure of SSRIs. Another reason for failure of SSRIs is, what is their function? Their function is to remove the serotonin out of the synapses, take it up, and then reintroduce it to the presynaptic, the synapse that releases the serotonin. So it removes it so it can be reprocessed. Well, the premise is there's serotonin available, but under the within the understanding that inflammation stops the ability of the neuron, because of peroxynitrite, neuron to create serotonin, to put it into vesicles, and to kick the vesicles into the synaptic or the cleft, that you don't have serotonin. So that's why the SSRIs don't work.
Because you haven't got serotonin in the first place to do that.
There's no serotonin. And it's the same thing that happens with Alzheimer's and the two medication used for Alzheimer's disease, Aricept and memantine. They anticipate to find acetylcholine. But what happens is there's no acetylcholine or diminished acetylcholine, because the same process, the inflammatory milieu in the brain, is stopping the acetylcholine from being made. And if it's made, it can't be packaged. If it's packaged, it can't be exocyclesis out into the synaptic cleft.
Yep.
So it's this change in chemistry. So another thing we found, it's in one of my lectures, is that this peroxynitrite damages an enzyme in the area of the brain called substantia nigra. And I'll come back to that in a minute.
Dopamine, Parkinson's.
So exactly. So what happens is, peroxynitrite has a predilection. It has a love for an enzyme system called glutathione reductase.
Mm-hmm.
So when you have in our body are two important free radical antioxidant pathways, and that is the glutathione pathway, which is a frontline pathway, and the other one is the SODS, or the superoxide dismutase pathway. So what happens is because of the consumption, the use of so much glutathione to stop the inflammation, especially after a trauma, the system gets overwhelmed and relies upon glutathione reductase to regenerate glutathione. But this peroxynitrite goes after the pathway to make the reductase, so you can't regenerate glutathione. And it's in the area of the brain, the substantia nigra, which has dopaminergic neurons that generate dopamine,
Yep.
which keep us from having Parkinson's.
Exactly.
So what happens is you need to go after the peroxynitrate's formation by lowering its production. We have something on the back burner that does that. And we have something that we're already using on the front burner, but we're more selective right now. And if you diminish the production of peroxynitrite, you do away with the loss of serotonin, the increase in kynureninic acid, the loss of the chemical pathways that make all our neurotransmitters, the destruction of the neuroreceptors, so you improve neurosynapses, so communication from neuron to neuron goes up. And we've got patients who have developed partial photographic memory. That's how good their neurosynapses are. Think of it this way. You've got, a cable that's a conduit from my house to your house. I'm here in California, you're in New Zealand, and it's got the cable through the ocean, and something happens and it gets cut. We lose information data flow. We lose that data flow. Now, if you go with a deep ship and you go and repair it, you reestablish that. Well, that's the exact same thing happening in the brain. You can't have effective hippocampus, which is the memory, recall, and the ability to learn new things in the brain. It can't communicate with the occipital lobe, so everything you see, you understand what you're seeing, or the occipital lobe with the parietal temporal lobe, so you understand words and how to put the images to a word.
And so this is all this peroxynitrate.
Correct. It's one of the worst ones.
So are there nutraceuticals or anything that can support that pathway, or is it only drugs that can? I had Dr. Nathan Bryan on the show.
I know Nate many years. Years we've known each other. Yeah.
Yeah, so he's a nitric oxide scientist. Amazing. When you say that nitric oxide is involved in that pathway, you spoke a little bit too quick for me there, probably to understand it. Is it because there's lots of positives of nitric oxide and having it, but there is also the inducible nitric oxide that we know from sepsis and stuff. And I've been a little bit confused on this topic, right? Can you explain that connection there? And is nitric oxide and getting blood flow to the brain, because for example, I have mum on Dr. Nathan's lozenges, is that a good thing?
I was on them 20 years ago when he started, okay? I had all my vets on it. Great reaction, for a great response from it. Yeah, there are a couple of different enzyme systems, and it's a nitric oxide synthetase. There's the inducible, there's the endothelial, the ENOS.
Yes.
And the ENOS is the one that generates nitric oxide for the intima, the lining of the blood vessels, so that they can relax. It's a smooth muscle, so it relaxes. That's a good thing. So when you take away the nitric oxide, the endothelial nitric oxide, you have vasoconstriction. And the PET scan or the SPECT scan, like Dr.
Perlmutter, Dr. Perlmutter.
Perlmutter, but
the other
Amon,
one, Dr. Amon.
Dr. Amon.
Yeah.
So Dr. Amon's, his whole thing is with the SPECT scan, picking up the areas of deficit. Well, those areas of deficit are clearly areas where the nitric oxide has been stolen, because understanding the neuroradiology of the SPECT scan, they inject you with a radioactive dye that piggybacks on the back of red blood cells. So what you're seeing are the areas of distribution of blood flow. So if it's smooth, what you see is a beautiful, vasculature. But when you have trauma with loss of nitric oxide in endothelial nitric, you see constrictions and punched out areas. I've got a slide, that animated slide that has actual video of a normal brain and a brain that has loss of nitric oxide, and you see all the punched out lesions.
Wow.
So that's the benefit of the SPECT scan. But you brought up about MRI, CT scan, all that. They're worthless because there's nothing that can tell you about the inflammation. The only thing that's close is the MEG scan, okay? The MEG scan, the magnetic encephalogram, which looks at the electromagnetic fields generated by neurons firing. So if there are areas of neurons, regions of neurons that are not firing because of disruption of their ion gate, that's another thing that gets interrupted, is the ionic gate, which is the channel that the different sodium, potassium, and chloride go in to generate reactions from the outside to the inside of the cell. So the gated ionic channels is the full name. And what happens is they're run by ATP. And when you have damage to the cell, they start leaking calcium into the cell. Well, calcium causes NMDA cells, neuron receptors, to trigger, and that's how you get the hyper excitability. The excitotoxicity is due to that, because
it's
what
due to the
happens,
calcium. So that's a
correct.
Yeah, because it's usually a glutamate thing, isn't it? We have too much glutamate.
Correct, and it all works together. Well, what happens is the inflammatory, another side of the inflammation is it interrupts the calmodulin, increases calmodulin, which allows for dumping of calcium into the cell. Things like ketamine, what ketamine does is it blocks that.
It blocks the calcium.
It blocks the calcium going into the cell.
Wow. Oh,
it's a what do they call it? They call it dissociative anesthetic. But look at I'm at a molecular level looking at how these things work, because that's the only way to understand. If you're at the basement, you can look up and see light, okay? But if you're already in the light, you're blinded.
Yeah.
Okay, so I look at everything from molecular, deep dive into the molecular. That's given me the understanding, a little bit of understanding. There's still a long way for me to go, and I've been doing this for 20, 30 years, So anyway.
So coming back to that peroxynitrite, so the nitric oxide is a positive. This is so those lozenges, for example, that's still a good thing to be taking, because most people have an uncoupled NOS enzyme by the time we're older.
Right.
And so that's not detrimental. Right.
It's a balance. If they are on they're on good anti-inflammatory, free radical scavengers. Free radical scavengers are things like testosterone, estradiol. Estradiol has a hydroxy group that actually makes it a free radical scavenger. Okay. It has an OH, it grabs an O, and a hydrogen makes water.
Wow.
Okay. So it inactivates through a couple of processes that I'm in the process of learning. But the issue I had, and Nathan and I have talked about this, is that if you're in an inflammatory environment and you add more nitric oxide, you got to take care of the free radicals.
The free radicals first. So you want to be, your N-acetylcysteines, your glutathiones, your vitamin C's, your antioxidant.
Gamma tocopherol, N-acetylcysteine, and gamma tocopherol will shut down the NF-kappa B pathway that leads to genetic signal that turns on our pro-inflammatory cytokines.
I interviewed Dr. Barry Tan. Do you know Dr. Tan? He's a tocotriene vitamin E scientist.
I think I might have his book here too.
Yeah, he talks about tocotrienols being much more effective than the tocopherols.
Absolutely. But, to educate the population, taking at least gamma tocopherol
is better than nothing.
Alpha, delta, and gamma. Gamma is the one that seems to be the best in the brain. Taking EPA, which is one of the taking
the
DHA,
fish oil,
which is part of the fish oil. DHA selectively in the brain downregulates the NF-kappa B, increases the survivin molecule and the protectin molecules in the brain, turns on some other ones, which all are neuroprotective. That's what we have to do, is neuroprotection. So what is the neuroprotection really? Getting rid of the free radical damage. modulating the inflammatory cytokines.
Yeah, no, absolutely. This is just, I mean, there's so many questions running around in my brain now. I interviewed
I'll
Dr.
stop so you can.
so I can ask stuff because these are, yeah, this is taking us into directions I never thought. But the calcium story, I've had Dr. Thomas Levy on the podcast as well, who's
Right.
he's written a book, Death by Calcium. I don't know if you know Dr. Levy, but he's a cardiologist and attorney of all things. Written 13 books, and he's written Curing the Incurable, which is a vitamin C story, the history of vitamin C. But he has one called Death by Calcium, and the osteoporosis story where we're just taking calcium, not a good thing. And he's saying, like, we don't want extra calcium in our body. We want it in our bones. We don't want it in the rest of the soft tissues. What do you,
Right.
you know, and the whole book's on that. And you were talking about calcium in the brain. I can imagine that being a very, very detrimental thing, and that the excitotoxicity that it would cause. So yeah.
If the parameters are correct or not correct, yes, it does increase the occurrence of it. And that's why we see people that when they're on ketamine, they get a great response, or they're on ketamine, they don't. So if they get a great response, it's already telling us that their problem issue with calcium overload is happening. Vitamin D and growth hormone together are phenomenal. You don't need, well, you do need vitamin D, but growth hormone helps to embellish the production of the 125
cholecalciferol. Yeah.
Yeah, helps with it.
Well, because growth hormone, let's talk about growth hormone next, because this is another huge thing. And there's a lot of scaremongering, and like growth hormone causes cancer and, this sort of stuff. Why is that not correct? And what do you use in your clinic when you're working with people? Do you use growth hormone or the secretagogues, or, the ipamorelins of the world, or the dinotropin and secretropin? What are they?
Right. Let's go to the question about cancer and growth hormone. It is a myth if you look at the whole picture. It's a truth if you look at just one avenue. Okay. And to try to put it as succinctly as I can, growth hormone, whether you inject it or you produce it in the brain, goes to the liver and turns on 10 proteins. Some of the proteins that it makes is IGF-1, okay, and IGF-2, binding protein, which are carrier proteins, 1 through 7 now. They found a 7th one. And then something called acid labile subunit, ALS. So you've got 7 carriers. ALS is a major carrier. And then you've got the IGF-1 and 2. Well, IGF-1 is promitotic, means it enhances the replication of cells. And it's because of this promitotic aspect of IGF-1 that all these fear mongers have said that, well, if you've got a cancer, it's going to cause it to accelerate. But we have something in our nucleus called P53, which is the strongest anti-cancer product in our body. So with that being said, the question I get is, so why are we seeing so much cancer? Well, we'll do pre-COVID, okay? We won't talk about turbo cancer. We'll talk pre-COVID.
Well, this is the P53 being knocked out, isn't it?
Well, the P53 is only being knocked out because of what we don't do correctly. It turns out that P53 has built into its molecular structure ions. And if you don't have those ions in the P53, it renders it relatively inactive. What does P53 do? It goes up and down DNA looking for mutations. If it finds a mutation, it will go ahead and try to fix it. If it can't fix it, it turns on P23 and P21, which are the apoptotic. They kill the cell. They're the planned cell death. Okay? So that's what happens secondarily. But it means that the P53 has to be functional. Without those ions in it, you lose it. And those ions are zinc.
Zinc. Wow.
Zinc.
And
so if you don't have adequate zinc in your body, what'll happen is the P53 won't be able to do its job. Okay? So
So that's a
What's sa-
huge cancer piece right there.
Yes. So what happens is IGF-1 will stimulate the cell to reproduce. If P53 is working well, it'll catch and fix or catch and destroy a mutating DNA. Okay, done, finished. But IGF-1 is only one. Binding protein 1, binding protein 2, 3, 4, 5, 6, and 7. It turns out that binding protein 3, the major carrier, is in the nucleus too. What does it do? The purpose of binding protein 3 is to absorb IGF-1. So if IGF-1 is pro-mitotic, binding protein 3 is anti-mitotic because it takes the balance, right? And it turns out that binding protein 4 is also anti-cancer. Okay, so 3 and 4. Binding protein 1, if it's low, heart attack, heart problems. Binding protein 2 deals with insulin resistance, so you get more diabetes. Okay, so coming back to the cancer mythology, so now that you've got the setup, P53 helps to kill cancer, P53 and binding protein 3 absorbs the pro-mitotic IGF-1. Okay, so what sits right juxtaposed genetically to the P53 genome?
No idea.
Binding protein 3.
Okay.
So every time you turn on P53, you get binding protein 3.
So it balances itself out.
So it helps to balance it out. So when you have a mutation, you see a spike in binding protein 3 to absorb the pro-mitotic IGF-1 and to make it a anti-mitotic environment because of P53, binding protein 3 and binding protein 4 being there, and P53 turning on the P21 and P23. So when you're using growth hormone, you turn on the entire system. So you need to look at the entire system. So as long as P53 is healthy, because you're taking zinc supplement, you're eating oysters, you're eating shellfish, you look, on Google and you'll see all the great foods, Brazil nuts with selenium, anti-cancer, the benefit of selenium, magnitude of benefits, anti-cancer, in organoselenium, which is in garlic, you can get the same benefits with selenium. And we use selenium methionine, which is methionine is the initiating amino acid for all our protein synthesis. So you improve protein synthesis. So,
oh my God. I mean, my mind's just blowing to pieces here. I'm just like, they're just dropping knowledge bomb after knowledge bomb here.
Well, this is because they're all contiguously important. They're part of the onion peel. We're peeling an onion. Okay. What we're doing is actually the onion's peeled. I'm putting it back together.
Yeah. Showing us the layers.
So the layers are there and they're all interactive. So you cannot just look at one aspect
and go expect. It causes, and so it goes growth hormone, goes down to the liver, and then it becomes IGF-1. So the IGF-1
turns on the manufacturing of everything in the liver.
All of these, and these are the most active components in the body, below the neck, sort of thing.
Right, so, and it circles back into the brain.
Right. And so we need, and growth hormone is reliant on estradiol and vitamin D, isn't it, to produce in the first place? And growth hormone goes down as we age.
Right.
So
vitamin, DHEA, testosterone, estradiol, vitamin D, I said, all regulate growth hormone. And in fact, about 10 years ago, what I saw in our labs, because I do, intense labs, is that women who were in mid-cycle had the highest amount of growth hormone. And then I go looking, it turns out the estrogen in the brain will increase the production of growth hormone. That's why I don't use any estrogen blockers in our males. Okay?
Because it drops their growth hormone. So when you use Arimidex or aromatase inhibitors, and because a lot of people are on too much testosterone, it goes down the estrogen pathways. The doctor goes, okay, your estrogen's too high, we're going to have to use an aromatase inhibitor. They block it, then they drop their growth hormone, which causes many deleterious effects. in the
Right.
brain
The
and body.
importance of IGF-1 in my literature on the work I do with the veterans with blast trauma, head trauma, NFL, NHL, soccer players from UK, Russian hockey players in the past. It's, you know, it's the inflammation from the hormone deficiency and the growth hormone deficiency from the estradiol because they're on too much testosterone. If estradiol goes up, it's because too much testosterone. And zinc is an estradiol, natural estradiol inhibitor. EGCG, which comes out of green tea, is another one. Curcumin. I mean, there's a whole litany of healthy, natural things you can use. The first thing to do, don't use testosterone before you try turning on your system if you have a history of head trauma or non-head trauma. What is that? We started talking about it.
Environment,
Yeah.
viruses, and
Yeah,
an
there are
inflammatory process.
subconcussive. Yeah, there's subconcussive, concussive traumas, and then there are non-traumas. Surgery is a
Surgeries,
trauma,
anesthetic, and the immune system activation that happens when you cut into the muscle and the tissue.
and that's cortisol. There
Wow.
was a study
Yeah.
done on women who were athletes, since you're an athlete,
Yep.
who broke their leg, and they monitored their menstrual cycle. And what happened was their menstrual cycles went totally off. What was going on?
Cortisol.
The stress of the fracture, the local production of cytokines, inflammatory components from the immune system below and above the neck, went into the brain and turned on the brain's inflammatory process, which shut off gonadotropic releasing hormone that regulates FSH for ovulation and luteinizing hormone.
LH,
Okay, so that's the cycle. The gut, if you've got an ulcer, gastritis, the same thing happens.
yeah.
So what happened was they found that these women were having abnormal cycles for 3 cycles, 3 months.
Wow.
Okay, and that's the inflammation. And when you brought it down, it was fine. So the benefit of growth hormone is, I think I've posted it on my website, a lecture that I do every year. We're on 2024, so it's growth hormone update. I've been heavily focused into growth hormone, which led to the development of the products that you talked about called secretropin and dinotropin. These are oral, 100% natural, no GMO, no junk components that stimulate your own production of growth hormone. Growth hormone is very dear in price, and therefore, you know, back in 2001, when developed for another company, this product called which was called Betatropin, and the owner of the company became a patient and handed it back to me, and when I did Secretropin, and it's a 100% natural growth hormone stimulating using 5 pathways. That's why it works better than things like CJC, Ipramorelin, Seromorelin, because they're single channel secretagogues. Ours is 5 channels. You know, they found, it uses 5 channels. One of the channels is arginine, which drops the production of somatostatin.